All right, guys, welcome back to Underground Science. In this video, we'll be talking about SLE, okay? So lupus, systemic lupus erythematosus. All right, so let's go and get started. So let's see how the mechanism works, okay? So this will make sense later, right, in a bit, but one one way, right, or one thing that can be present in lupus patients, right, is a deficiency in certain complement proteins like C1q, C4, and C2, okay? And we'll see why this can lead to autoimmunity as we see in lupus. Okay, so let's start with the mechanism, right? The most famous mechanism um, is let's talk about this UV rays, right, that come from the sun. All right, and UV rays. We're going to take the example of UV rays damaging your keratinocytes, okay, so your skin cells. And if they damage your skin cells, you get normally what happens is you get apoptosis. Remember, apoptosis is non-inflammatory. Okay, there's no inflammation associated with it. So if you have apoptosis, right, you get cell destruction. Okay, and macrophages usually come in, clean it up, and you're good. So if UV rays hit your keratinocytes, right, it damages your DNA. You get apoptosis. So you get basically nuclear material like DNA and histones, right? Fragments of those, fragments of nuclear material that basically can leak out, right? Normally, though, what should happen is you should have normal complement proteins like C1q, C4, and C2. Okay. Now, why is this important? Because C1q can actually directly bind these nuclear fragments. Okay. So, so what are these nuclear fragments again? Right? These are double-stranded DNA, right? So what are these? Let's label this. So these are double-stranded DNA. We also have histones that can leak out, right, due to apoptosis. And we have short nuclear ribonucleoproteins, right, SNRNPs, which we know can combine with certain Smith proteins and become SNRPs, which are important for when we talked about splicing, right? So So these nuclear materials, right, that leak out due to cell damage from UV rays can be double-stranded DNA, histones, and snRNPs, right? And then what should happen is your complement system, like C1q, can come and bind these fragments, right? And once it binds, remember our complement system, C1q then activates R, C1R, then C1R activates C1s, then C1s cleave C4 and cleave C2 to make C4b2a, which is C3 convertase, right? So then you get C4b2a, which is C3 convertase, which C3 convertase breaks down C3 into C3a and b. And we know C3b is a major opsonin. So what happens is C3b then comes in and also binds onto these fragments, right? And then macrophages actually have receptors for C1q and C3b. So then macrophages come in, right? And they phagocytose and eat these fragments up, right? And then get rid of them, right? So that's how these macrophages clean these fragments up due to apoptosis, due to UV damage, right? But this, but there was no inflammation here, right? No inflammation, tissue damage, or excessive tissue damage, excessive inflammation, right? Like you would see in necrosis, for example. And thanks to your complement proteins, right? Because your complement proteins helped your complement proteins like C1q did what? It attached onto these nuclear fragments and then helped macrophages get attracted to it, and then so that the macrophages could clear it away. Why do you want the macrophages to clear away these nuclear fragments? Because this is self-antigens, right? This is present inside your cells. You don't want your own nuclear DNA, histones, short nuclear ribonuclear proteins, right? You don't want your snRNPs, histones, and double-stranded DNA just hanging out outside your cells, because then it gives your immune system more time act on it, and then you may release antibodies against your own tissues, right? So it can lead to autoimmunity. So you want nice levels of C1q and C4 and C2 so that your complement system can bind onto these fragments, attract macrophages, so your macrophages can come and quickly clean it up without any inflammation and autoimmunity. This is what happens normally, right? In apoptosis. But in lupus patients, you can see complement deficiency in C1q, C2, C4. So if you're deficient in these complements, you can't properly tag these fragments for your macrophages to come and clean it up. So then that means these nuclear fragments stay out of the cells for a prolonged period of time, okay? And which is bad because if you have self-reactive B cells in the vicinity, right? What can happen is your self-reactive B cells can take up those fragments like which is what? Double-stranded DNA, histone, snRNP, right? Smith proteins. They can take those fragments up through their IgM or IgD B cell receptor, internalize it and present it on MHC class 2. And who responds to MHC class 2? CD4 T cells. So if there's a self-reactive CD4 T cell, it can interact, right? The T cell receptor of the self-reactive CD4 T cell can interact with the self-nuclear fragment, whether that's DNA, histone, or snRNP, for example, right? Or Smith proteins. And then we have CD4 that binds MHC2, and then remember we have the CD40 binds the CD40 ligand, and that activates the T cell, the self-reactive T cell, who can now release interleukin 4 and 5, which will lead to this self-reactive B cell differentiating and class switching into IgG secreting plasma cells, right? Which will lead to IgG antibodies against who? Against this, right? What was this? DNA, or histone, snRNP, Smith proteins, right? That leaked out from your inside of your cells, your skin cells, right? Due to the UV rays. So then you generate antibodies against your own DNA, histone, and overall your own tissue. So then what happens now is these antibodies can then go and bind to your DNA or your histones or your snRNP, right, or your Smith proteins, and make a complex, antibody antigen complex. These immune complexes then can enter your blood and go to various different tissues and deposit. When immune complexes will deposit, right, once they deposit into various different tissues, which we will talk about in a bit, right, immune complexes attract complement proteins. So now you have all of these immune complexes that are depositing in various tissues, bunch of complement systems getting activated, right? So you have a huge activation of complement system. So you're going to have a lot of C1, a lot of C4, and then that will combine with C2 to make C4B2A, right? C3 convertase. You're going to be breaking down a lot of C3 into what? C3A and B, right? And then that will go on to form C5 through C9. And remember, complement will attract and activate neutrophils and macrophages, which will further lead to more tissue destruction, and the cycle repeats, right? Even the neutrophils can damage your endothelial lining also, okay? Your endothelial lining. All right. So again, right? All of these antibody antigen complexes can deposit in various tissues, activating complement, therefore depleting complement. Okay. So one thing we need to mention, right, is interferon alpha, okay, which I just came to mind. So remember, right, if you don't have proper levels of C1q, C4, C2, these self antigens, right, DNA, histones, your own snRNP, can stay outside of your cells for too long, and then dendritic cells can phagocytose these antigens, right? These new fragments. Now, what's part of these fragments, as we mentioned? DNA, right? Well, in your dendritic cells, right? So let's say this is your DNA, histones, snRNP, whatever, right? So let's say this is the DNA, part of the product of the apoptosis, right? Due to the UV rays damaging keratinocytes. And then let's say this is your snRNP. right? And what are we considering? We're considering the fact that this patient is, sorry about that. We're considering the fact that this patient is deficient in what? We're considering the fact that this patient is deficient in your C1q, C4, C2, right? So that means these fragments, nuclear fragments, stay around for too long. Your macrophages can't come and clean it up. So dendritic cells then will come in and try to phagocytose these fragments, right? Remember, this is DNA, right? In your dendritic cells, we have toll-like receptor 9 who responds to DNA. And in your dendritic cells, we have toll-like receptor 7 that responds to RNA, right? And this is all in your endosomes, not on the cell surface. So imagine if the dendritic cells will start to phagocytose these and activate the toll-like receptors, which will lead to massive cytokine release. And remember, toll-like receptor 7 and 9, right, eventually lead to the activation of IRF7 when we talked about in that video, in the other video, right? And IRF7 leads to the production of interferon alpha in this case. And you produce a lot of this. Why is that bad? Well, interferon alpha, right, increases MHC expression, right? It actually promotes survival of B cells. And in this case, we're talking about autoimmune B cells, right? Self-reactive B cells. And it helps increase the activation of T cells. So interferon alpha, right, is promoting your immune system, right? The activity of the immune system. So, and this is actually, so if you, like, let's say, for example, right, if you increase your B cells, right, survival of your B cells, and we said that in lupus, right, you can have self-reactive B cells that escaped central tolerance, for example, and that's what leads to your autoantibody production, right? So that means interferon alpha will promote more autoantibody formation, right? So you'll have more IgG, right? Which will target your DNA, your snRNP, your histones, right? So you're going to make, so what are the IgGs, right? These IgGs are anti-histone, right? It can be anti-histone, it can be anti-Smith, it can be anti-double-stranded DNA, right? And so on. So you make these complexes then go and deposit into various tissues, right? And immune complexes attract complement proteins. Okay, so it's going to deposit in your tissues. Then you're going to attract complement proteins like C1, 4, 2, 3, and then C5b through C9. We know forms a membrane attack complex, right? So what happens is you actually consume a lot of your C4 and C3 because of the excessive activation of complement throughout your body, right? These antigen antibody complexes are depositing in various tissues of your body. And those tissues, once these complexes deposit, it activates the complement system, right? And at the end of the day, you activate, so the complement system starts with C1, remember? Like especially the classical pathway, right? Remember, we talked about this in another video, C1, then that leads to eventual activation of C4 and C2, and actually breaks apart C4 into C4A and B, right? So we have C4B is the main part, then C2A, right? These combine together to form what? C3 convertase. C3 convertase breaks down C3 into C3A and B, right? So if what we're seeing, what happens is in these patients, due to excessive complement activation, you actually deplete your levels of C4 and C3, okay? So that's an important finding. You can find low serum. Let's write that down. It's an important finding. In these patients, in these lupus patients, you can find low serum C3 and C4. All right. So as we said, things like C3A and C5A, right? So this should say C5A. Sorry about that. C3A and C5A, right? What do these do? These can activate, these can attract neutrophils and macrophages, right? So if it attracts your neutrophils to that area, wherever these antigen antibody complexes are, right? If there's blood vessels nearby, it can damage the endothelium, as we mentioned, right, before, damage the endothelium, and it can lead to tissue necrosis too, right? Because what do neutrophils do? the neutrophils will try to come in and try to get rid of the antigen antibody complexes, right? In the process, though, how does it try to get rid of that? It releases a bunch of reactive oxygen species and a bunch of proteases. Okay, and this is what will damage your endothelial lining and tissues, right? And can lead to tissue necrosis. Okay, and imagine if this is all if your antigen antibody complexes, if these deposit into your glomerulus, right? Into your glomerulus and basement membrane, right? Then well, let's say in this example, let's say the antigen antibody complex is depositing in your glomerulus. Then if this leads to complement activation, then attracts neutrophils. And if your neutrophils start releasing all these reactive oxygen species and proteases, then it's going to damage the endothelial lining of your glomerulus, right? And that can lead to proteinuria, right? You can damage the glomerular basement membrane because, and we'll actually talk about that in the findings right now. So that's the basic mechanism of how antibodies form and how lupus works. Okay, so that's the autoimmune reaction that occurs in lupus. All right, so I hope this made sense. Okay, because now we're gonna go talk about the findings. All right, so let's go talk about the findings. All right, so if we scroll all the way up, right, because there's a lot of findings in lupus. Okay, so we talk about these. So, if these antigen antibody complexes deposit in the skin, right, that can lead to inflammation and rash, right? So you can see a malar rash, your butterfly rash, and discoid rash, right? So discoid rash, you would have scarring plaques with central atrophy. Okay, that's important to keep in mind. So it can affect the skin. Then it can affect your kidneys, right? In which we just finished talking about. So if antigen antibody complexes, right, deposit into your kidneys, it can lead to lupus nephritis, right? Which can lead to nephritic syndrome, okay? Where you have hematuria, right? Blood in your urine, RBC casts, right? You'd see RBC casts. You may even see proteinuria also, right? And you can also see high blood pressure, right? Because if you're losing proteins and fluids, right, that can trigger increased renin release, which can lead to high blood pressure. Okay. And one of the main renal pathology that we should know for related to lupus, it can lead to diffuse proliferative glomerulonephritis. Now we'll talk about this in our renal playlist, but what happens in here, right, is you get the antigen antibody complexes depositing in the subendothelial space. Okay, so remember, you have your afferent arteriole, right, and you have your tuft of capillaries, and then your efferent arteriole. Okay, so and then you have your basement membrane like this, your basement membrane with your type 4 collagen, right? And then you have your Bowman's capsule like that. And I'm drawing it like a lot of space between each just to for the diagram so I can show, right? Bowman's capsule, and then you have your podocyte lining here, right? This is your podocyte lining. So these antibodies, right, can deposit the antigen antibody complexes can deposit subendothelial, right? So beneath your endothelium. And what this leads to is this can lead to more inflammation, right? More complement activation, inflammation, attracting neutrophils, right? And this can make the walls of your capillaries of your glomerulus really thick, okay? So you can see things. So a saying, right, or a phrase you can see is wire loops, okay? So it looks like wire loops, which is an important phrase to keep in mind, all right? So it can make the walls of your capillaries of your glomerulus super thick, okay, which isn't good. All right, so remember, we get certain autoantibody production, right? So let's say this is nope, not red. Let's say this is anti double-stranded DNA antibodies, right? Bound to its antigen, right? It's bound to our double-stranded DNA that leaked out of our cells in the beginning, right? When we talked about the UV rays. And this can deposit subendothelial, right, in the subendothelial space of your glomeruli. And then what can happen is, due to all the inflammation, your mesangium can proliferate, right? Your endothelial lining will proliferate, and that can lead to wire loop lesions, right? Which is just thick, your thick walls, thick capillary walls of your glomerulus due to the subendothelial immune complex deposition, right? And 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 then this can lead to, this is a type of nephritic syndrome, right? Diffuse proliferative glomerulonephritis is a type of nephritic syndrome seen in lupus patients, because what this will lead to, again, we said mesangial proliferation, thick capillary loops, right? And and you can also see, of course, you'll have neutrophil infiltration, which will lead to further damage, right? Because they release reactive oxygen species and proteases. But then we know in nephritic syndrome, you can see hematuria, right? So in here, you would see hematuria, right? Proteinuria. You can see RBC casts. Because of this relating to lupus, remember, you can see low C3 and low C4, right? And then, of course, you can also see elevated blood pressure, remember, because of increased renin activation, so hypertension. And remember, right? Remember this when we talked about oncotic pressure. When you see proteinuria, one of those proteins that filter through the glomerulus or leak through the glomerulus and into your urine is albumin, right? So if you're losing albumin, you have less albumin in your blood vessels, which means you cannot keep fluid as well in your blood vessels. So fluids start leaking out into your interstitial space. Okay, and this is going to lead to edema. So that's something you can also see in nephritic syndrome. Okay, as well as nephrotic syndrome too. All right, and if this keeps on progressing, it can lead to renal failure also. And especially remember nephrotic syndrome, the proteinuria is greater than 3.5 grams a day. In lupus nephritis, you can see proteinuria that's also greater than 3.5 grams a day. So it's nephrotic range proteinuria, okay? And of course, hematuria, you would see colored urine too, okay? So that's how you'd see hematuria. So that's basically diffuse proliferative glomerulonephritis, which we maybe went a little too much into, but we're going to talk about this anyways in the renal playlist also. But another nephrotic syndrome you can see due to lupus, right, is membranous nephropathy. Okay, so this can lead to nephrotic syndrome where we see that spike and dome pattern. Remember that. So we see here, we can see a spike and dome pattern, right? And these in membranous nephropathy, the antigen antibody complexes can deposit subepithelial. Okay, so right here between the basement membrane and the podocyte layer. Okay, so again, right, in membranous nephropathy, you see these antigen-antibody complexes deposit in the subepithelial region, not subendothelial, subepithelial, which is right below right below the basement membrane, and between the basement membrane and the podocyte layer. Okay, so again, this can lead to basement membrane thickening. Okay, so membranous nephropathy, let's write it here, can lead to basement membrane thickening and eventual nephrotic syndrome, in which, what do we see, right? In nephrotic syndrome, we see massive protein loss, so much greater than 3.5 grams a day loss of proteins, like what, like albumin, antithrombin 3, and antibodies, right? So if you're losing a lot of albumin, you can expect low oncotic pressure in your blood vessels, means more fluid to leak out into your interstitial space. So you can expect a lot of edema, right? And remember, if you're losing a lot of albumin, your liver can produce a lot of cholesterol molecules, right? So you can have hyperlipidemia, okay? So you can have hyperlipidemia, and so on, okay? But we're gonna cover nephrotic syndrome in the renal playlist, okay? So let's talk more about the kidneys, right? So I mean, we already talked about this, so let's do a quick review and move on. Okay, so remember, we have immune complex deposits, our anti-double-stranded DNA, right? Antibodies deposit in the subendothelial space, which is right here, as shown here. This is when we're talking about diffuse proliferative glomerulonephritis. Remember, this attracts complements, right? So you get your whole classical complement cascade, right? And that depletes your C3 and C4 levels. Okay. Now, these deposits make wire loop lesions, right? It can lead to GB. It can also deposit in your glomerular basement membrane too, okay? Diffuse proliferative glomerulonephritis can deposit subepithelial and in your glomerular basement membrane, right? Which can eventually lead to glomerular basement membrane damage, okay? And thickened capillary loops, okay? Thick wall of your capillaries. And then eventually that can lead to nephritic syndrome, right? Diffuse glomerulonephritis is a type of nephritic syndrome, okay, because of the glomerular basement membrane damage, right? If your basement membrane is damaged, then we know that can lead to hematuria, proteinuria, edema, hypertension, RBC casts, and so on, right? Just what we see in nephritic syndrome. Okay, so that's lupus nephritis, okay? Specifically diffuse proliferative glomerulonephritis, okay? It's always hard to say that, but so you can again in diffuse proliferative glomerulonephritis, you can see wire loop lesions, and that's due to the thickened capillary loops. Okay, the thickened capillary walls because of the subendothelial antigen antibody deposition, complement activation, neutrophil infiltration, a lot of inflammation, right? And you also see mesangial proliferation, okay, because of the increased inflammation. All right, so I think I went a little bit too deep in that, like in a little bit too repetitive, but hopefully it made sense, right? Another body system that lupus can affect is your cardiovascular system, right? So it can affect your endocardium, leading to Liebman-Sachs endocarditis, and these are sterile vegetations on your on your valves, right? But it's Liebman-Sachs endocarditis, which is sterile vegetations on both sides of your valve leaflet. So if this is your valve leaflet, not just sterile vegetations here and here, but on both sides. So on that side and this side, okay? This side and that side, both sides. That's Liebman-Sachs endocarditis. Okay, it can affect your pericardium, leading to pericarditis and pericardial effusion, right? It can affect your myocardium, leading to myocarditis. And it can even accelerate the atherosclerosis process, which can eventually lead to clots. And that, that won't be good if it's like your coronary arteries, your arteries that feed your brain that can lead to adverse events. Okay. Next system that that lupus can affect, right, is your hematologic overall, right? Overall hematology, right? Meaning if you're having self-reactive B cells produce antibodies, you can also produce antibodies against your red blood cells, leading to autoimmune hemolytic anemia. You can produce antibodies against your white blood cells, leading to leukopenia. You can produce antibodies against your platelets, leading to thrombocytopenia. Okay, so that's that. Like that's also bad. And if you in lupus, right, you can also produce antigen antibody complexes, and it affects your brain, it can lead to psychosis and seizures. Okay, and then not only can it affect your heart, it can affect your lungs, right, your pulmonary system. So if these antigen antibody complexes, right, deposit in your pleural layer of your lung, that can lead to pleural effusion due to increased inflammation and fluid production. And it can also lead to pleural chest pain, right? So every time you breathe in and your lungs expand, right, your pleura cover your lungs. So if that's inflamed, it's going to hurt, right? So that's going to lead to pleural chest pain. And then remember, these antigen antibody complexes, right, can also deposit in your joints. Okay, that's going to lead to arthritis. So, especially if it's greater than or equal to two joints. Okay, and it's non-erosive. That's important because in rheumatoid arthritis, as we'll see in the future, is erosive. Okay. And in lupus, you can also see oral and nasopharyngeal ulcers, which are usually painless. Okay. And those are the main findings. But remember, we need to have the antibodies down, right? So the main antibodies to know in lupus is that you're positive for ANA, right? Anti-nuclear antibody, positive for anti-double-stranded DNA antibodies, positive for anti-Smith. You can be positive for anti-Smith. You can be positive for anti-phospholipid antibodies also, right? So that brings us to our next discussion is what are anti-phospholipid antibodies? Okay. Now we're going to talk about we're going to talk about antiphospholipid syndrome in the next video. So, but for now, let's just state the antiphospholipid antibodies, okay? But before we do that, it's another review, right? Remember, you get antigen antibody complexes and deposition in multiple tissues that activates complement system and depletes your C3, C4. Remember, CH50 will also be depleted because what does CH50 measure? The amount of complement proteins in your blood. But you're deficient or you depleted your C3 and C4, therefore your CH50 will be depleted too. Okay. So anyway, moving on to antiphospholipid antibodies. What are these, right? These are autoantibodies against proteins that are bound to phospholipids. Okay. So it's antibodies against proteins, and these proteins are bound to phospholipids. Okay. So what are these antiphospholipid antibodies that we should be familiar with? One is anticardiolipin or anticardiolipin antibodies, right? Now you can see anticardiolipin antibodies in a syphilis infection also. So that means that you can have a false positive syphilis test, right? Like if you see anticardiolipin antibodies in lupus, because this is a what antiphospholipid antibody, right? It's one of the types. So that you may think, okay, well, the, 'cause you may think that okay, this patient may have syphilis also, right? So you can if you were to do a VDRL and RPR test, and it comes back positive for anticardiolipin, it can be a false positive syphilis test. It can be a false positive result, right? Because what's the VDRL and RPR testing for? It's testing for the anticardiolipin antibody, right? For syphilis. But if you do this and then it comes out, oh, you do have anticardiolipin antibodies, right? But then the patient also has lupus, so that means that it may be this anticardiolipin antibody may be positive because of lupus and not the syphilis. That's why you can get a false positive test result if you do the VDRL and RPR test, okay, for syphilis. All right. Because remember, you can see anticardiolipin antibodies in a syphilis infection. So that's that, right? And then another antiphospholipid antibody to be familiar with is lupus anticoagulant. Okay. This is an antibody, and what it does is actually increases your risk of thrombosis, so clotting. Okay. But the weird thing is it falsely elevates your PTT. Okay. So this is a false elevation of your PTT, right? But the false elevation part's important, right? Because when you're doing the activated PTT test, right? The lab test, what happens is in that test, what happens is the PTT, the activated partial thromboplastin time test, right, uses the phospholipids, it uses certain phospholipids, okay, that activate the intrinsic pathway. So if we were to diagram that out, right, when you do in the lab test, right, when you do the PTT, what is that, right? The PTT measures what? The intrinsic pathway, okay? But how does it do that? It uses in the test, okay, in vitro, it uses certain phospholipids to activate that pathway, okay? So in the PTT lab test, it uses certain phospholipids, right, to do what? To activate the intrinsic pathway, which we know it starts from factor 12, 11, 9, 8, right? But if you do the PTT, right? If you measure the PTT of a patient with lupus anticoagulant in their blood, what lupus anticoagulant does, right, is it binds to these phospholipids that do what? That help activate the intrinsic pathway. So that means now the intrinsic pathway cannot get activated properly, and so this will falsely prolong your PTT, right? So if the lab test comes back as a prolonged PTT, right? That's actually false if we're talking about lupus because of lupus anticoagulant. Because we know lupus anticoagulant actually increases thrombosis risk despite the name, right, which has anticoagulant in it. So if the PTT comes back prolonged and you suspect lupus anticoagulant, if you mix the patient plasma, right, which has lupus anticoagulant with the normal plasma, then you should see it, if it's a factor deficiency, right? Then you should see the PTT correct. Okay. But if there's lupus anticoagulant in the patient plasma and you mix that with normal plasma, the PTT will stay prolonged because a lupus anticoagulant will continue to bind to the phospholipids that help activate the intrinsic pathway. Okay, so the PTT will stay prolonged. Okay, that's what lupus anticoagulant does. It falsely prolongs the PTT. All right. And of course, antiphospholipid antibodies, right, increase increase the chance of clotting, which is bad because this can increase your DVTs, right? Deep vein thromboses. It can increase your risk of pulmonary embolisms. It can increase the risk of miscarriages, right? And even stroke, right? Even stroke, and increase the clots, increase the chance of clots forming in your hepatic vein, cerebral blood vessels, and so on. Okay, so this isn't good, right? Antiphospholipid antibodies make you basically more hypercoagulable. Okay, and it's just important to know these antibodies because we're going to talk about antiphospholipid syndrome in the next video, right? Remember, anticardiolipin antibody, right, is also present if you do a in syphilis infections, right? Can be also present in syphilis infections. So if you were to do a VDRL and RPR test, right, in order to test for anticardiolipin antibodies, right? And you if you actually had the syphilis bacteria, right? The bacteria that causes syphilis, if you had an infection due to the bacteria, right, that causes syphilis, then you would, and if your immune system produced anticardiolipin antibodies, right, and respond to the syphilis infection, then the VDRL and RPR test would come back positive for anticardiolipin antibodies. Okay, but we should also know that if you do this test, right, and then it'll come back positive for anticardiolipin antibodies, like we mentioned. But remember, in lupus, you can have anticardiolipin antibodies because that's one of the antiphospholipid antibodies seen that can be seen in lupus. So it's going to be a false positive syphilis test. Okay, that's important to know. It's a false positive syphilis test. Okay, because if you do these tests and it comes back positive, doesn't mean you have syphilis. It means that you're just producing this antiphospholipid antibody, right? The anticardiolipin antibody due to lupus, not due to syphilis infection. Okay, so I don't like over explain that in a loop, but it's important to know these antibodies. Okay, and then of course remember lupus anticoagulant antibody, and another antiphospholipid antibody that we should be familiar with is anti-beta 2 glycoprotein 1 antibody. Okay. And again, we'll talk about antiphospholipid syndrome in the next video. Okay. So I hope this video on lupus made sense. I know it was too long. Okay. I hope it wasn't too confusing. I hope it made a little bit of sense. I hope it helped a little bit. Thank you guys for watching. See you guys in my future videos.